they say, this is a direct quote out of the CPC Plus information, quote, "The guiding principle for the selection of utilization measures for CPC Plus is a parsimonious list of actionable measures that drive total cost of care." Don't make me say it again, Scott. I'll make you say it.
Word of the day is parsimonious.
We figured that was on the calendar for that day when they wrote those. You know, it's like, how can you use this in a sentence? But anyway, the translation is, for all these various CPC programs, there are two things that they really want to achieve. Obviously, they want your quality to be good, that the patient be well taken care of, but they make no bones about the fact that what their driving force is to affect inpatient and ED costs. And it is written on every single page and in the structure that they expect you as a CPC Plus practice to be doing. The common elements amongst all these programs, besides the PCMH look feel of the program, is that all the programs have some variation on pay for performance. And depending on which program it is and who the payer is, that's going to take a little bit different look to it. But everyone gets paid for performance, for quality, and to a certain degree for structure of your practice. All programs at this point have a requirement for transitional care management, that is following a patient after he or she has been discharged from inpatient, and some also have an ED requirement. All programs monitor the ED's discharge or utilization. It may not necessarily track to your payment, but some do. We'll look at that. And then for the payments for chronic care management, which all the CPC models do, some will also receive a bonus payment, but some will not. And this is one of those inconsistencies about how CMS set up these programs. The ambulatory programs that fall within the same bucket are the CPC Plus, which is, or Track 1, which is the basic PCMH model involving chronic care management. You get a per member per month fee. You get that on a quarterly basis with a potential bonus at the end of the year if you're not an ACO model. And we won't get into the fact that you get paid in advance for that and you're at risk. But the Ohio CPC, which is Medicaid, very similar, different costs involved as far as what you get paid in your per member per month, much lower fee, but very similar structure. And the difference between the Medicare and Medicaid is Medicare is driven completely by practice site. And I think that's a huge difference in both the business of managing these payment programs and also your general thinking about your quality and your how your practice is going to be structured. The Medicaid program is much more geared to the organizational level, which isn't all bad. It's a lot easier to manage that if you've got 10 or 12 CPC sites, but it also has its own set of issues. Then the commercial payers who are involved in this will come into two buckets, and we'll look at that on the next slide. The last thing I'd say is MIPS does not require transitional care management, but you do get bonus points in the clinical practice improvement area, and for some of the other MIPS places it shows up. But so it is, transitional care management is really the word of the day for 2017. The payers I divide into two buckets. Those that are Medicaid managed care, the Buckeye, CareSource, Molina, Paramount, and United Healthcare, are the ones that will be working with you on the Ohio CPC. And the significance of that is they will be linked into what the standards and requirements are for the Ohio Medicaid CPC. The commercial payers on the left side, who also signed up to participate in CPC Plus, are not necessarily linked to what Medicaid's requiring, because they aren't the Medicaid managed care people, but it's not totally clear what additional requirements they might have beyond what CMS has set up. They're supposed to stay within the same structure, but how they pay you and what type of monitoring is done is something we'll just have to wait and see. Okay, all of you, I'm sure, know, or if you don't know now, certainly you'll dream about it by the end of the year, the areas that you will have to work with in your practice. And for those of you who are PCMH, you've already sweated through this at least once, if not twice. You have the increased availability, the question of 24/7 access, no matter how that's termed, care management, care coordination, patient and family engagement, and planned care and population health. So let's go back. This is for Medicare. The increased availability, I'll tell you all what we're hearing. I just want you to be aware of it, is that the way these programs are being set up, that there is going to be monitoring, because that has been the question. I know we posed it to CMS, and we haven't had a direct answer, but I've been monitoring all the information, and this is what I'm coming down with. You've got to report your quality. They review your utilization on the claims. The question of this practice structure and whether you're meeting all the clinical requirements was, how do you document that? Well, what we're hearing is that this first one, especially the scheduling stuff, you know, are you scheduling same-day appointments? What are you saying as far as after-hours coverage and stuff, is actually going to be run kind of like a secret shopper program, in the sense that people will call and see what you say about getting same-day schedule, and or how you're handling after-hours care. And I've got to tell you, I mean, this wasn't funny to the practice, but I mean, just so that you all are aware of it, we had a practice that is PCMH certified that received a call, interestingly enough, from one of the payers. And I do believe that the payers will be doing some of this checking up on your structure, and that the payers definitely on the Medicaid side, I believe, will do it. I don't know about Medicare, but the reality in this one site, the payer called kind of as a secret patient, you know, asking about scheduling, and the doctor was never aware of the fact, but they were short that day, and so their message at 2 o'clock in the afternoon was, if we aren't in the office right now, and if you have any problems, you can go to the emergency room. Not really the answer you wanted to have when you wanted to show that you were giving extended hours. And she actually received a call from the payer saying, did you know that, you know, you're not meeting this extended coverage? So I anticipate that you may have a similar type of situation. So those of you who have not gone through the PCMH and are yet CPC Plus, I would urge you to review all of the work that your staff is doing that are what I call patient-facing work. You know, how's the phone answered? What's the message? What's the message if they're asking to be seen immediately? What is your message on the phone after hours? Do you refer them someplace else? And what do you say about the ability to get records? So that's, as far as increased availability, I would definitely look at that as you get into this program and starts rolling. Care management. This is the one we're going to spend a lot of additional time on, and this is the transitional care management. Huge, huge part of this program, and we'll see how that can be fulfilled. Care coordination is the same thing. This is more your chronic care management and has a lot of more bells and whistles about how you manage patients besides just within the office setting. Patient and family engagement, you all are aware that you're going to be subject to the CAHPS survey, and that if you're part of the ACO, I'm going to guess that they're going to use the same CAHPS survey for both ACO and CPC Plus. I know CPC Plus is using the PCMH model, and I think the ACO uses very similar. And then the population health is your quality improvement activities. Medicaid looks a little bit different in the sense that what they're saying is they have these activity, efficiency, and clinical measure categories. The activity area, which is the PCMH clinical requirement model, is they're saying that you have to be doing all 8 of these requirements in order to receive your payment or receive your bonus, definitely. But I'm thinking underlying payment if you miss that over several months. So be aware of that they're saying 100%. You have to meet all of this. And if you look down at, it's very similar to what we just looked at for Medicare. And you do have the requirement for follow-up after hospital discharge and follow-up on tests. Efficiency measures is where you fall into the question of ED visits, and we'll look at that. And then the clinical measures are the 50% of all your quality metric. And don't forget, with Medicaid, you are not going to be reporting for either your efficiency, which is your cost, or your quality. Those are all going to be tracked at least this year on claims. Now, what I wanted to look at is specifically where transitional care management and the ED utilization come into these programs. So under transitional care management after an inpatient discharge for Medicare, you have to, under the Medicare requirements, you have to show that you have contacted at least 75% of the patients who are discharged from the hospital within 2 days of discharge. So I'm sure many of you recognize this as the underlying requirement for billing for a transitional care management fee, is that 2-day contact followed by a 1 to 2 week visit. But to see it specified in 75% of the cases means that you really have to have a strategy to get that information about the discharge from the ED, and then what you'll see also from, the inpatient and also from the ED. Medicaid also requires it, although they don't put it in those specific terms, and the commercial payers are going to require it. Transitional care management is also used for scoring your bonus points in Medicaid. It is not part of the bonus in Medicare, but it is a requirement for the program. We don't know whether the commercial payers are going to make transitional care management part of any increased fee that they would pay you. For the transitional care management after an ED visit, in Medicare, you have to make that contact within a week. Medicaid requires the contact, does not specify the timeline for that, but obviously the sooner the better. The same thing is true with Medicaid. Will include your work with patients who have gone through the emergency department towards scoring bonus. So that is something that Medicaid's very big on, is that you're following up on those patients. The same thing is true for inpatient visits. Use the scoring bonus for Medicaid and also for the private payers. But then look at this last line on this page, and that is the utilization rate for behavioral health related inpatient admissions. So we're really stepping into a different area here. The behavioral health linkage in Medicare goes to the Track 2 sites, as you all know. And so there's going to be an expectation that you are following those behavioral health cases if you are a Track 2 Medicare CPC Plus site. But for Medicaid, that is one of the requirements for some of the quality metrics, and we're going to look at that. And obviously, the cost factor is factored in all the way through for Medicaid, including the utilization of hospital and inpatient or ED. Okay, now what we're going to look at a problem and then talk about how the HIE functionality can support it. So I'm going to turn it over to Scott to talk the technical side of it. But what we're going to be talking about here is the functionality called Notify, and he'll show how that meets those requirements for CPC.
So whether it's CPC, CPC Plus, or if you're a MIPS provider that's doing transitional care management, the biggest problem you're going to have is knowing when one of your patients was seen in the ED, admitted or discharged. You might have a good relationship with a facility that's close to you, or if you know you're a larger healthcare system, your providers may have access to some information. But let's say you're a Columbus-based physician and your patient falls in Cleveland, breaks his arm. How are you ever going to know? Well, that's what this tool called Notify does. Notify really supports your care management, your transitional care management, allows you to stay apprised of your patient activity or movement across the continuum. You're going to get an alert. Anytime a patient is admitted or discharged from any care facility, any participating care facility, and it's going to give you enough information to go from a reactive state to a proactive state. It's going to change the conversation with your patients. You know, you're going to be able to reach out and say, hey, I saw you were in the ED last night, rather than 2 months down the road, your patient comes in the office and says, oh, by the way, I was sick a couple months ago and went to the ED. It's going to completely change the interaction between a provider and patient. Now, what Notify does is it's really built upon what we call ADTs, or Admission Discharge Notifications. So anytime your patient goes into an emergency department, is admitted or discharged from the inpatient setting, it creates an alert. We are able to direct that alert to anybody who has stated that they have a relationship with that patient. We're going to talk a little bit more about that in a few minutes. In addition to just getting the general alert, we can do a readmission alert. Now, there's a little bit of a limitation here with the readmission alert, in that it has to be same patient going to the same facility more than once in a 30-day period. But you will get a different style of alert that'll be logged as a readmit. Now, Notify is a subscription model service, and again, it's automating the delivery of the ADT health event notifications regardless of where they happen at any of our 150 participating hospitals. Now, this application is really designed for your case managers, your utilization managers, care teams, chronic care management teams, to really quickly be alerted, especially for those high-risk patients. So Notify does work in near real time. We say near real time because, boy, we would love to, as soon as they admit that patient or they register the patient, to notify it just immediately. But it takes a few minutes for it to work its way through our system. But the key is you define through the application the when, where, and how that message gets delivered. We set it up so that you receive alerts in the style that is the style that is going to be the biggest benefit to you. We can send you a standard email alert or a standard text. Now, those will not have PHI. It's just going to say, hey, you have a patient alert, log in to see what it is. We can send a direct message. Since direct is secure, we can put a little bit more PHI in that. I believe we say it's, it's patient name at facility name. And the interface that I kind of like the best is we can post to a work list. So you would log into a website and be presented with a work list of, here's the patient, here's the facility, here's the time of the event. So that way, if you have multiple people, you have a care management team or chronic care management team that works together, they can all log in. As they're working through that work list, the patients, they can kind of check off that they've spoken to that patient or they've addressed that issue. Some folks like a report. We can provide you with a daily report that will have all of your patient alerts on it. Now, how do we tie patient to provider? We make it simple. You tell us. You upload a patient list. Again, to make sure we adhere with HIPAA, you should only upload a list of patients for which you have an active patient-provider relationship. But by you telling us, this allows you to kind of specify or specify the group of patients that you want to manage or grow into the program. So let's say you want to start with the top 10% of your high-risk patients. So maybe you want to start with a number in mind. You say, hey, I want to start with 5,000 patients. I want to start with my diabetic patients. We don't care. You upload the list. Anytime an event happens for any of the patients on your list, you will get a notification.
Yeah, and so one thing I'd say about this, in light of the way CPC is structured, even if you're part of a larger organization, I would encourage you to have this done at the site level, which you just have to be identified in our system, differently, so that that information flows to the site and not to the organization, because you're going to have your own panel of patients that have been assigned to you as part of CPC Plus or Medicaid or one of the private payers, and that will give you the opportunity to have that information come back to you, unless you have a different care management structure, because some of you, if you're part of a larger organization and that organization does the care management rather than the individual sites, you just have to think that through. Who you want to get notification to, who's going to be working your list.
And we can set it up multiple ways. Maybe you have multiple care teams. Let's say you've got 3 care teams. Those care teams are assigned certain providers or certain locations. Maybe those care teams one care team wants the work list set up, another one wants the daily report, another one wants the active alerts. We can do that. We can set this up any number of ways. But the real underlying benefit of this tool is the impact it can have on your 30-day readmission rate. And let's face it, CPC Plus, MIPS, the hospital programs, everybody is looking at 30-day readmits. What is the #1 way to lower your 30-day readmit? To get that patient in the office anytime they have an ED event or they are discharged from the hospital. If you can get them in, you can go through their meds, you can talk to them, see how they're feeling, you can keep them from going back. And that's what this tool is all about. This is available now. If you are interested in Notify, you really want to get moving forward on it, we're going to give you some contact info at the end of this. With that, I'm going to turn it back over to Cathy.
Okay. Hey, thanks, Scott. All right, let's look at the quality metrics and see how that fits in with the HIE and if there's something that is there that will help you with your quality work. As you all know, as CPC Plus sites, you have the 3 groups of quality measures that you have to choose 9 measures through. And the biggest thing about these, for those of you who do ACO work, you know that the CPC Plus is an overlay of ACO, because there's, I don't know, like 8 of the measures are identical to those that you track in ACO. So it makes it kind of easy which ones you want to track and report on. But just make sure you go through this. This reflects CMS's priorities right now. Let's go back and look at that one by one. You've got a couple of depression measures. This is huge. I think we started seeing those last year or the year before. But a lot of quality programs are asking for depression information. Then you get into our 2 biggies and favorite ones, diabetes and hypertension. Everyone should be tracking those regardless. And then you get into question of elder care, whether it's risk of fall, whether it's dementia, high-risk meds. Those are all elder care issues, alcohol and drug dependence. And then you get into what are basically your preventive care measures. So it kind of gives you an assortment of things that you can track and work your quality metrics in. Look, the second one from the bottom, the use of imaging studies for low back pain, huge emphasis on this. Other than the inpatient and ED visits, I would say that imaging is the next highest priority for most of, or certainly for Medicare and Medicaid, but I think for a lot of the commercial payers, you will see huge emphasis on that. And so what you're going to be looking for is the ability to track what people have done in some of these areas where you might not necessarily have been the ordering provider, for example, with a mammography. That does not require a physician referral. And so if a patient has that, is it getting back to you? Do you know about it? So those are the Medicare ones. Medicaid, I threw these up because it has the thresholds that Medicaid's going to be tracking on, which I think are quite interesting. But your 4 areas are your pediatric and women's health areas, which are not as common if you're not in either a pediatric or a OBGYN type practice. But they are definitely ones that you could be tracking if you have any type of pediatric population. Adult health are pretty much the standard ones, and the behavioral health is kind of the area where Medicaid gets into it at a much greater depth than Medicare, except for the Track 2 patients, or Track 2 CPC Plus sites. But look at the thresholds. I just found that fascinating. The thresholds for Medicaid, for the most part, are so much lower than the benchmarks that you see across the, say, PQRS, or what are now going to be the MIPS standards. For example, A1Cs, I think the national threshold is probably about 20% this year, so 20, 25. And Medicaid is going to be at less than 90%. So if you've got less than 90% of your patients as representing A1C out of control, then you're considered, that's a successful metric for you for that year. So look through that. I just find that real interesting.
This speaks to the population, the patient population.
Well, you don't know whether it's patient population, part of it's that, part of it's that the patients move amongst the various managed care.
And it's the claims-based tracking.
Right, and see, that's the other thing. These are claims-based, so you're not reporting on it, but you need to be aware of it. Look at the controlling high blood pressure, 10%. If you have 10% of the hypertensive population, less than 140/90 on their blood pressure, then they're considered to be, you're considered to have a successful quality reporting for that metric for Medicaid for that year. So you have to meet 50% of these standards, but I just wanted to point that out because that's kind of a new piece of information that Medicaid's put out that I think people would want to review. So those are the Medicare and Medicaid. Here are the quality metrics that I think you could have some assist with by using what's called the community health record in the HIE. So as I was saying, the imaging studies for low back pain, this has been, as those of you who work with physician practices know, that this has been forever a problem. Physicians just, it gets their dander off when they hear that there's going to be a quality metric that links them to whether or not there's been an x-ray on somebody's low back pain, because usually those people present to the ED, and the physician's like, why should I get judged on that? Well, what this is going to do is give you the ability to see what reports are out there, what's coming back from the ED, how many of these people are being x-rayed on the very first shot in the door. And if your physician has practices at that, or privileges at that hospital, and he sees that, he or she sees that, you know, in 60–70% of the time, the patient's getting an x-ray as soon as they walk in the door, then that may be a discussion that they want to have with the quality committee at that hospital. But it at least gives you information that was not available on an ongoing basis. You've got your lab result ones, I think, are always big. Your A1Cs, some of the cervical cancer screens, colorectal. Now that one's going to depend on what type of testing you did for colorectal cancer screening, because some of that is office-based, but some of it is hospital-based also. Diabetic eye exam. Now this is one that everyone's still struggling with. Every site we're at is still kind of fashioning how they're going to get this information. We are working on pilots with the optometrist and with the big optometry vendor to see about getting that not only integrated into the community health record, but as discrete data. So we will keep you posted on that, but recognize that type of information would be posted to the community health record as soon as you get an optometry or ophthalmology practice participating in it. as I said, mammographies we already said, but closing the referral loop, I think this is really worth noting, the advantage of the community health record, and Scott's going to show you that in just one second. But closing the referral loop by pushing information and pulling information from the community health record, you automatically close the referral loop, and then you are left with a much smaller task list as far as follow-up on any patients that were seen elsewhere. Okay, with that, I'm going to have Scott talk to you more specifically about what the community health record is, how it's being used within the state, and how that supports your various quality metrics that you are going to need to be drawing information for.
Now, what this graph is showing is for 2016, the growth in the number of queries, the number of times folks were logging into the CHR and querying a patient. As you can see, we were kind of doing a controlled rollout early on and started pulling in more certain customers, and now we're kind of wide open with it. But you can see we went from under 100,000 to over 250,000 at the end of 2016. I would venture a guess we're well over 500,000, if not more.
Yeah, and when we're saying the community health record, we really didn't define that. Many of you are working with it and you're familiar with it, but for those of you who aren't, this is really the longitudinal health record. It is all the information. We have information now from the beginning of the HIE, so it's well over 10 million patients. There's data points for each one of those, and it's available to be accessed for other treating providers.
So right now we have over 370 organizations that are a consumer of information using the community health record. And this includes hospitals, health systems, ambulatory practices, pharmacies. The Kroger pharmacy is one of our big pharmacy customers using the CHR. Long-term health loves this tool, behavioral health, and of course we have the several medical neighborhood groups. Now, that's consumers. The contributors right now are the 150 participating hospital members. We're also bringing up, we have quite a few ambulatory practices right now that are also contributing clinic notes and other information. But CHR will include, of course, all the structured lab results, all of the radiology results, discharge instructions, just any document that the hospitals are sharing with the HIE. And it is a pretty broad set of information. And now that we're bringing up ambulatory, that's going to close 2/3 of the care continuum. Very soon we're going to get into the long-term and post-acute space. That is going to close the care continuum as far as from the what we consider to be the traditional care settings, as far as having the complete patient story available.
Right. So no matter where the care is provided, if you post the CCD to the community health record, not only do you have the discrete lab results no matter where they were done, but then you have those individual documents as well as the ability to create your own document.
Right, and this is really meant to serve as a supplement to direct results. So, we strongly recommend that all the ambulatory practices out there integrate with the HIE to be able to receive results discreetly into your system. That way you have that information within your EHR. You're always more efficient within your EHR experience, but then this serves as a further supplement. Now, what I'm going to show you today is what is our web interface to the community health record. We do support a direct EHR integration through an interface that's called IHE. That allows the EHR to do an interactive or a semi-interactive query, and it will present a certain. It's very dependent on how your EHR has implemented the IHE. We also support single sign-on, and the single sign-on, if supported by your EHR, can pass both the login and patient and contacts. So it would fire right from your EHR and pull up, John Doe and see all of John Doe's information. But again, we're going to look at the web interface. It is the most simple interface that we can provide. And it's extremely simple. You log in. You put in some patient information, first name, last name, date of birth, if you have the SSN, if you have your medical record number that from the hospital, some subset of information. What will then happen when you hit search, if you just put in Scott Mash, it would present all of the Scott matches that we have indexed in our master patient
Oh,
index.
there can only be one Scott. There can only be one Scott match in the state of Ohio. It's not the nation, really.
But when you are presented with that list and you select a patient, it will then ask you, if you've never accessed that patient before, if you have a treatment relationship with that patient. That ensures adherence to HIPAA. When you have that information, again, this is just a quick screenshot from the CHR. You can see here that we have patient summary tab, encounter tab, results tab, meds, documents, referrals, tons and tons and tons of information. We're waiting on an upgrade that will allow the CCDAs that have been contributed to be consumed down to their discrete elements with respect to problems, allergies, meds. I believe vitals as well.
Yeah, but for right now, you can create your own CCD based upon the information that is currently in the community health records. So say you saw labs and RAD reports that you wanted to draw in, you know, any information on that patient, then you just hit the button to create your own summary, and then you can either download, print, or send that.
So let's say you have a patient coming out of the hospital. You know, if you have results delivery set up, integrated with your EHR, if you order a lab, you're going to get that lab back. You're going to get that result back. But if your patient's in the inpatient setting and they run labs in there, you're probably not going to get those results sent to you directly. But there's a lot of clinical relevance there when you're seeing that patient in a transitional care management setting. You go into the CHR, you query the patient, you've got the discharge instructions, you've got all the results for the labs that were ran during that patient's stay. If they had a radiology result, you're going to be able to see the transcribed results. You're going to have all the transcribed documents. This subset of information is only going to get better over time as we bring up more ambulatory sites, as we start working with post-acute, as we bring up a few pilots with optometrists to get those diabetic eye exams back into the system. It's only going to get better. This is available right now as a standalone web interface and to integrate with your system through, if supported by your EHR, through the IHE interface or through single sign-on.
Right, and our HIE people out in the field can answer, I'm sure you're going to have questions about, you know, the question of the web portal versus the single sign-on, and they can answer and tell you which vendors we're integrating with on that. But what I'd say, and we're going to look at the two areas of the MIPS program that are supported by the HIE, and then talk about the documentation on HIE. So the one thing, this area is going to be necessary for everyone. No matter what CMS says, everyone's really going to have to report the old meaningful use, or ACI. I mean, it shows up whether it's in a quality metric or it shows up in a requirement for the program. You're going to have to report this either as a group or individually. One of those requirements, and it'll bump up your score significantly if you have technical integration, because that is one of the areas that CMS is recognizing that's going to give you 10% bonus points on your ACI score. So keep that in mind. If you're using direct, you're using the HIE through the community health record, those are categories that will get you the 10% bonus point. The other area where it shows up in MIPS, not necessarily that CPC Plus needs to worry about this, but if you have other providers that are not CPC Plus, you have this clinical practice improvement area that has, you know, 50, 60 different categories that you need to get points in. All the ones listed are ones that you can get 10 or sometimes 20 points that involve use of the HIE. So it's really just take your time and determine your strategy around it, but the HIE can help you in so many different ways. And what we have talked internally, because all these programs are so new, about the best way to support you all. And what I think we're going to do is, as people sign up, if we know you're part of a alternative payment model that requires transitional care management or chronic care management, we can provide you with a summary of what types of functionality you are contracted for. So that would be part of your documentation. Should you have one of these secret shopper type of calls, or if one of the payers meets with you and wants to determine how you're handling this, you could, have this ready and say, it could spell out the fact that your organization has this functionality.
And if you are an ambulatory provider, if you're an independent physician out there and you would like to contribute data to the EHR, you would like to share your clinical information, please call us, let us know. Think about the CPC Plus requirement for 24/7 access to the care plan. Well, if you're contributing data, you're contributing that care plan to the HIE, not only is it available to you, the provider, but it's available to everybody who cares for that patient, whether it's the ED, whether it's a specialty provider. They could all get into the HIE, query that patient, and see the primary care provider's care plan there, just readily available.
Right. Okay, so if you're interested and you want us to send one of the HIE folks out to meet with you so you can talk about, how to get this done, timeline, how you upload panels and stuff, contact Dottie. Many of you know her already. She's our Director of Communications, and she will make sure that the correct HIE liaison person contacts you, gets back to you, and, gets you underway with this project so you in turn will meet your requirements for your reporting program. And then the last thing I'd say before we open it for questions, if you're part of a small or rural practice and you need a little more guidance about how that's going to look as far as MIPS, Lord knows that we all wonder the same thing. But anyway, we are going to have a couple webinars on that next week, so you're more than welcome to join that. And with that, I'll turn it over to you, Scott, and let's see if we have any questions here.
If you do have any questions about these overlapping program requirements, please feel free to contact Cathy or myself. We're always willing to help and answer questions. The one question we have is, will a recording of this webinar be available? Yes, we will post a recording of this webinar to the CliniSync YouTube page. Just go to YouTube, type CliniSync. You'll find our page. We have tons of videos there. Cathy and I have done, probably a dozen webinars recently covering MIPS, APMs, CPC Plus, and we try to record all of our sessions. Now, if we are running a session where we're running it multiple times, we will post what we consider to be the best of those, but then we post a Q&A from every one of those sessions. Let me check one other spot to see if somebody maybe put a question in the chat panel.
Yeah, there's one right there.
Oh, that's just a thank you for joining. So any of the attendees, since we're on the phone, if an attendee has a question that they would like to ask us via voice, if you just quote-unquote raise your hand within the GoToWebinar app, we can unmute you real quick. Right now I don't see anybody, but we'll hang on for another 5 or 10 seconds. I think that's it.
We really appreciate you spending late afternoon time with us, but we hope to see you all out in the field, and happy hunting as far as getting your programs up and going, and we'll be interested for your feedback. You have a great day, and we'll talk to you soon. 5 categories that will get you the 10% bonus point. The other area where it shows up in MIPS, not necessarily that CPC Plus needs to worry about this, but if you have other providers that are not CPC Plus, you have this clinical practice improvement area that has 50, 60 different categories that you need to get points in. All the ones listed are ones that you can get 10 or sometimes 20 points that involve use of the HIE. So it's really just take your time and determine your strategy around it, but the HIE can help you in so many different ways. And what we have talked internally, because all these programs are so new, about the best way to support you all. And what I think we're going to do is, as people sign up, if we know you're part of a alternative payment model that requires transitional care management or chronic care management, we can provide you with a summary of what types of functionality you are contracted for. So that would be part of your documentation. Should you have one of these secret shopper type of calls, or if one of the payers meets with you and wants to determine how you're handling this, you could, have this ready and say, it could spell out the fact that your organization has this functionality.
And if you are an ambulatory provider, if you're an independent physician out there and you would like to contribute data to the EHR, you would like to share your clinical information, please call us, let us know. Think about the CPC Plus requirement for 24/7 access to the care plan. Well, if you're contributing data, you're contributing that care plan to the HIE, not only is it available to you, the provider, but it's available to everybody who cares for that patient, whether it's the ED, whether it's a specialty provider. They could all get into the HIE, query that patient, and see the primary care provider's care plan there, just readily available.
Right. Okay, so if you're interested and you want us to send one of the HIE folks out to meet with you so you can talk about, how to get this done, timeline, how you upload panels and stuff, contact Dottie. Many of you know her already. She's our Director of Communications, and she will make sure that the correct HIE liaison person contacts you, gets back to you, and, gets you underway with this project so you in turn will meet your requirements for your reporting program. We really appreciate you spending late afternoon time with us, but we hope to see you all out in the field, and happy hunting as far as getting your programs up and going, and we'll be interested for your feedback. You have a great day, and we'll talk to you soon.